I'm Dr Ruth Collins. I'm a urological surgeon here at the Sound Hospital and I also work at Concord Hospital. I think one of the common misunderstandings is that incontinence is just something that happens after you've got older, delivered babies, and that it's a normal part of getting old. Although it's more common after those things, I don't think we should ever consider incontinence as a normal part of ageing. And also I think there's a misconception that the only treatment is surgical, and a lot of women put off even asking for help because they think, oh, I don't want to have an operation, not realising that in fact we operate on a relatively small proportion of women with incontinence, and there's so many non-surgical treatments that can significantly improve incontinence, resolve incontinence and improve someone's quality of life. And I think because incontinence develops so gradually in a lot of women, they adjust, they minimise fluid intake, they go to the toilet often, and it's only when you treat it that they realise how much it affected so many aspects of their life. And giving them that improvement, you literally do change people's lives, and often with really quite simple strategies. So in terms of the non-surgical treatment, around 2/3 to 3/4 of women will be happy with the degree of control you can give them without even picking up a scalpel or taking them into theatre. The primary surgical treatment for stress incontinence is to place a sling supporting the middle of the urethra. Stress incontinence is actually a urethral pelvic floor problem rather than directly a bladder problem. And the issue is that you've lost some physical support around the back of the urethra, usually because of delivering those babies. So the surgical procedure is to put a supporting sling around the urethra. It's not pulled tight or else you can't pass urine. It's literally there to essentially catch the urethra when there's a lot of downward pressure from coughing, running, gym work. So it's a supporting sling, and that's internationally a standard treatment for stress incontinence. It's been around for nearly 20 years now. It's tried and tested, and it's a good operation. Whereas for overactive bladder, urge incontinence, if you have a patient that's not responded to non-surgical treatments, usually the next step is to inject bladder Botox. So injecting Botox directly into the muscle component of the bladder. And what that does is it actually helps relax the bladder, which intuitively, I think most people think relaxing muscles when you've got incontinence, that can't be the right thing, but we're relaxing the bladder, not the pelvic floor. So the bladder doesn't suddenly switch on and empty when you don't want it to, and that's how Botox works. In terms of dry rate, it's 85 to 90%, although Botox does wear off over time, so you may need to repeat that treatment. But again, across the board, the improvement in terms of quality of life with these treatment options is extremely high for procedures that really are minimally invasive, short procedures not requiring anything more than an overnight hospital stay at the most. And minimal complications post-operatively, and patients generally very satisfied with the outcomes. Two commonest things that I hear when I see patients at the post-op follow-up. The first one is, I wish I'd had this done ages ago. And also, another common comment is, you've given me my life back. Being able to just engage in all the fun things in life, particularly with an overactive bladder and urge incontinence, that becomes a very challenging issue when you get out of your normal environment. Where's the toilet? What happens if I have to hang on? So all the fun things, getting on an aeroplane, going on an overseas trip, going to the theatre, going somewhere where you don't know where the toilet is, previously becomes impossible, and people just stop engaging with those activities. Fix the problem, they can do all those things again, and that has a major impact on someone's quality of life.